Welcome, everyone. Thank you for joining us tonight for our presentation of Overcoming COVID-19, a Historical Perspective. This webinar is the latest in an educational series being presented by the Minnesota chapters of Physicians for a National Health Program and Healthcare for All Minnesota. Physicians for a National Health Program is a national education and advocacy organization of over 20,000 health professionals and patients who support universal health care through single-payer reform. Our vision is a Minnesota where all get the care they need, and our mission is to educate, advocate, and research in order to build a single-payer health system that achieves health equity for all Minnesotans. Healthcare for All Minnesota is dedicated to promoting affordable, high-quality healthcare for every Minnesotan through advocacy, education, and community organizing. PNHP and HCA-MN have created a joint education committee. Together, these organizations are committed to working with and educating our neighbors and fellow Minnesotans about the choices that they have in healthcare. Our presenter this evening is Dr. Kenneth Engelhart. Dr. Engelhart represents both organizations, and we welcome you this evening, Doctor.
Thank you, Jen. Thank you much. Well, we'll go ahead and get started with the presentation. We'll be talking about the U.S. response to COVID-19, and then we'll be talking about what should be done to improve our response and how Medicare for All would be beneficial. As Jen mentioned, my name is Ken Engelhart. I'm Chair of Physicians for a National Health Program, Minnesota, and I'm a board member of Healthcare for All Minnesota. I have a private practice experience of 25 years, and at the last 10 years of my career, I worked at the Minneapolis VA Medical Center, so I also have that public sector experience. All those years, I was a primary care provider and saw patients in primary care clinics. While at the VA, I was also the clinical chief for the section of general internal medicine, supervising 40 primary care providers and clinical operations within primary care. This quote has meaning for us tonight. The past is behind, but we need to learn from it. The future is ahead, and we have to anticipate and prepare for it. And for today, we need to live it, by Thomas Munson. So as I start the talk about past pandemics, I need to first talk about the greatest pandemic of all time, which is actually not a viral pandemic, but rather a bacterial one. The rest of the pandemics you'll be hearing about tonight are viral in origin, but the Black Death was caused by a bacteria. That pandemic also goes by the name of the Great Bubonic Plague, or the Great Plague. It was the most devastating pandemic in human history. It peaked in Europe in the mid-1300s and caused 75 to 200 million deaths in Europe and Asia. The mortality rate was 30 to 60% of the European population. It started in Asia, then through the Silk Road moved over to Crimea, and from there got on Genoese merchant ships to the Mediterranean and Europe. I liken this pandemic to hitchhiker's disease because it seems that all the actors in this pandemic were catching a ride from somebody. So it starts with the green bug on the right-hand side of your screen. That's the Yersinia pestis bacterium. So that bacteria caught a ride on fleas, and the fleas caught a ride on black rats, who also caught a ride on ships, which distributed this infection throughout Europe and Asia. So what would happen is that this bacteria would end up choking off the gut of fleas, making the fleas very irritable, and led to the fleas biting people. And that's how the bacterial Yersinia pestis that caused this plague was transmitted to humans. The Black Death caused great societal changes. Food prices and land values went down, land values going down as much as 30 to 40%. And for ordinary people who were able to survive this Black Death plague, it was a windfall for them because it improved their living conditions so much. And actually what happened was the Black Death was the end of feudalism, where there was the lord who owned the property and the peasants were able to live on the property and work for the lord. But the Black Death ended that system of feudalism. Now this slide shows past influenza pandemics that are caused by viruses. We'll start at the bottom of the slide, and as you see down there, it reports for a typical flu season a mortality or death rate of 400,000 people throughout the world. And then next you see the Russian flu from 1977 and 1978 that had a mortality rate of 700,000 people. Next, the Hong Kong flu in the late 1960s, anywhere from 1 to 4 million people dying from that viral infection. Next, you see the Asian flu in the late 1950s and the death rates there. And the main viral pandemic we'll be talking about tonight, as far as past pandemics, is the Spanish flu from 1918 to 1920. And the death rate there varies depending upon which study you look at, and there are 3 studies listed. The lowest one lists 17.4 million deaths, and the highest one in the middle, up to 100 million deaths. But the main takeaway from this slide is to know that pandemics, viral pandemics, are not rare or atypical. As you see, we had one at the end of the 1950s, we had one at the end of the 1960s, we had one at the end of the 1970s. And so viral pandemics are not rare. Pandemics spread by droplets, and this slide clearly demonstrates how many droplets are being spread when someone coughs or sneezes, and up to 500,000 virus particles can spread to those nearby. Now, the Spanish flu, depicted by the microscopic picture of the organism on the right-hand side, killed more people in 24 weeks than HIV/AIDS did in 24 years. I mentioned previously that estimates of the annual baseline number of worldwide influenza deaths is 400,000, but that of the Spanish flu far exceeded that, with a mortality range anywhere from 17.4 to 100 million people. It had a mortality rate of 1 to 6% of the world population, and Rosser writes that influenza pandemics are not rare, but the Spanish flu of 1918 was by far the most devastating influenza pandemic in recorded history. This is a picture of an emergency hospital set up for military personnel from Fort Riley, Kansas, and you can see the place is just packed with people infected with Spanish flu. The Spanish flu pandemic did not spare the president of the United States at that time. President Woodrow Wilson was even infected with the Spanish flu. And I particularly like this quote because I think it's important for leaders to have a certain degree of humility. And the quote by Woodrow Wilson stating that I not only use all the brains that I have, but all that I can borrow, admitting that he does not know everything and he has to rely on experts who can help make decisions. Now, the Spanish flu pandemic of 1918 to 1920 is just that. It actually lasted for 3 full years, from early 1918 all the way to the end of 1920. And it came in 3 different waves, which you can see outlined on the graph here. You see that the middle wave was the highest wave in terms of mortality per 1,000 people. And the reason for that is, after the first wave, the virus mutated to become more virulent and caused more mortality in the second wave. Now, the Spanish flu is kind of an atypical name for a viral infection. Actually, it's a misnomer because it really didn't start in Spain. It's named Spanish flu because Spain was neutral in the First World War, and therefore they were free to write about the flu affecting their country, where the countries that were involved in World War I were afraid to write about their infections because it decreased morale and made them look weak to their enemies. So they did not really talk much about the Spanish flu affecting their countries. But because the Spanish people had publications talking about how the flu was affecting their country, that's how the name Spanish flu began, because it looked like there were so many cases coming out of Spain. So that's where the name originates. The Spanish flu was the last time in history when world population was declining. It was devastating because young people accounted for a large share of the population, unlike most influenza or other viral flu pandemics, which disproportionately affect the elderly and frail people, not the young. During the Spanish flu, infants and young people were most at jeopardy. Nearly 50% of deaths from the Spanish flu occurred in the age range of 20 to 40 years of age. But the life expectancy of 60 to 70-year-olds in the Spanish flu was unchanged. And the reason for that was they were exposed to a Russian flu pandemic in the late 1800s, and it was the same H1N1 virus that caused the Spanish flu from 1918 to 1920. So because they were exposed in the late 1800s to the same virus, the 60 to 70-year-olds at that time in 1918 through 1920 actually had immunity, and their life expectancy was not affected at all because they were immune to the Spanish flu virus. That Russian flu in the late 1800s had a mortality of 1 million people. Now, unlike today, where we have antibiotics, back in 1918 through 1920, there were no antibiotics available, and the majority of deaths were from secondary bacterial pneumonia caused by common upper respiratory tract bacteria that we have in our upper airways. And these bacteria moved down into the lungs that were weakened because of the initial viral infection. The Black Plague, as I mentioned earlier, had an effect on history, and so did the Spanish flu. It favored the Allies in the later days of World War I, such that there was more morbidity, meaning more people infected, and more mortality in the Central Powers of Germany and Austria than Britain and France. So it affected Germany and Austria more, and had some impact on how World War I turned out. Now, this is a chart of life expectancy, and I think it's important to show this to you. We talked about life expectancy declining during the Spanish flu, and you can see here in the late, in about 1918, right there where this dip is, life expectancy went down. But the main reason I want to show you this slide is you see all these countries listed. And all of these countries, with the exception of the United States, has what we call universal health care, where everybody in the country has access to health care. Nobody is left out. And all of these countries are single-payer countries, except, of course, the United States. But also Germany is not a single-payer country, and Singapore is not a single-payer country, although they do have universal health care. It's worth mentioning the tiny country of Georgia. I didn't know this until recently, but they are the country with the most recent passage of single-payer health care for their country. That happened in 2013. So it'll be interesting to see what happens over the years with Georgia in terms of how they do and their outcomes with single-payer universal health care. As far as life expectancy, all these universal health care countries, most of them being single-payer, have a greater life expectancies than the United States. We're only ahead of Georgia in terms of life expectancy compared to these other countries. So let's talk a little bit about coronavirus, this one here in the upper left that you see so often on TV, and the Spanish flu virus. The coronavirus is different. It has affected humans, it's infected humans on 4 different times. 7 different times. On 4 of those times, it was just simply an upper respiratory infection that didn't have much consequence. Another time was the 2003 SARS infection that happened. And more recently, the 2012 MERS infection. It's the Middle Eastern Respiratory Syndrome infection. So SARS stands for Severe Acute Respiratory Syndrome, and MERS stands for Middle Eastern Respiratory Syndrome. Interestingly, the MERS infection in 2012 was called the camel flu because it was thought to spread from camels to humans, with the camels originally being infected by bats. So we've had 7 coronavirus infections up to date, if you count the current COVID-19 infection we have now. So when we compare Spanish flu to the current COVID-19 infection, we're talking about coronavirus versus the Spanish flu H1N1 influenza virus, 2 different viruses. Now, coronavirus is typical, more typical of viral infections in that it's more lethal in the elderly than infants and adults less than 50 years of age. And also, in the times that we live now, infections can spread more rapidly because of plane travel compared to the 1918 to 1920 period of time when people traveled more by railroads and steamships. Also, we now have antibiotics to combat bacterial infections that may set in following an initial viral infection. But antibiotics actually were not available for Spanish flu because penicillin was not discovered until 1928 by Alexander Fleming. And we also have better nutrition than we had back in the early 1900s. We have less overcrowding, we have better sanitation. Living conditions are better worldwide than they actually were back in the early 1900s. And the World War I caused a weakening of much of the world population and depleted resources. And that led to being more prone to being infected with Spanish flu and having a poor outcome. So Rosser writes again about the Spanish flu that it has been cited as a warning and a motivation to prepare well for large pandemic outbreaks, which have been considered likely by many researchers. So we have to learn from the past and anticipate for the future. Now I'm going to talk about some lessons that we've learned from the current COVID-19 pandemic. And I'll talk about countries that have employed these measures to lessen the impact of COVID-19 on their countries. So these are basically what you could call the 12 commandments of how to manage a pandemic such as we're currently experiencing globally. First one is be prepared. Second one, be quick. Third, test, trace, and quarantine. 4, use data and tech. 5, be aggressive. 6, get the private sector involved. 7, act preventatively. 8, use tech but respect privacy. 9, you can drive-through test. 10, learn from the past. 11, test more as restrictions are eased. And 12, build capacity at hospitals to handle surges that happen. So Dr. Tom Frieden was a former director of the Centers for Disease Control, and he has a very nice, concise way of describing how we should approach the management of pandemics. It's called Box It In. The first is testing, and we've been behind in testing since the beginning. Some people call our failure to adequately test the original sin in this country as far as this pandemic is concerned. So step number 1, test. Number 2, once you know by testing who's infected, you isolate those who are infected. Number 3, find out who has been exposed to the infected person. This is called contact tracing. And 4, those people who have been exposed to the infected person should self-isolate for 14 days. All of these steps are to reduce the spread to other people for a very contagious disease. It is so important, though, to know who is infected and to take these actions. And if you can't test properly and know who's infected, you're essentially flying blind in the course of management of a pandemic. So what we're going to look at now is total confirmed COVID-19 cases. These are cases in various countries. I'll be talking about the United States, but I'll be talking about these other countries in the lower right. And the United States number of infected cases is this graph here. As you can see, it far exceeds these other countries that have managed the COVID-19 pandemic well. And these are the number of people infected in the various countries. The second slide I'm going to show you, it's current as of today, is the death rate from COVID-19. Again, the United States is way ahead of these other countries in terms of deaths. And here are the countries we'll be talking about who managed the pandemic well. We became the world leader in the number of infections on March 26th, and on April 11th, we became the world leader in terms of number of deaths. These are two categories where we certainly don't want to be the world leaders. This slide shows the total and daily confirmed COVID-19 cases in the United States during that period of time before the public safety measures were less restricted. So it's from April 20th to May 7th when our safety measures were relaxed. And remember, in a previous slide, I had mentioned that the Trump administration advised in April that there be a 14-day downward trajectory of daily new confirmed cases. So if you look at the bottom line, that is daily new confirmed cases in that 14-day period before the May 7th relaxation of public safety guidelines. And there is no downward trajectory seen. In fact, what you see there is a pretty consistent daily new case report of cases ranging from 20,000 new cases a day to 29,000 new cases a day. No downward trajectory. That's very concerning because already we've seen in successful countries such as Germany and South Korea and Singapore, as well as the country of China, that when public safety measures were relaxed, there was an increase in new cases. So the fact that we didn't follow our own direction as a country with a 14-day decrease in daily new confirmed cases is concerning. And in this slide, you can see the ever increasing number of total cases in this country, now over 1.4 million. Let's talk about Singapore first. It has a highly rated healthcare system. It was ranked number 2 of 166 countries for outcomes by The Economist magazine and has the longest life expectancy in the world at 84.8 years. People live on average 84.8 years in Singapore. It's supervised by the government Ministry of Health, and it's kind of a complex system for financing based on direct government subsidies, compulsory savings, national health insurance, cost sharing. So it's got a complex financing mechanism. It's very unique, and it is felt that to try to replicate the health system in Singapore would be almost impossible for any other country because of unique circumstances. It's a small, rich island nation without rural areas, without a hinterland. It's been ruled by one political party for nearly 55 years since independence. The local media carry the government's measures and advice without any question, and basically do whatever the government asks them to print and publish or broadcast through the media. And also Asian culture is such that they have a willingness to place community and societal needs over individual liberty, which is helpful in a public health crisis. Towers Watson, a global consulting firm, said it would be very difficult to replicate the Singapore system in other countries. So what did Singapore do? They enacted aggressive, sustained early measures. They did draconian testing and containment with their small population that was largely accepting of government's expansive orders. It was one of the first places to ban incoming flights from Wuhan, and they had a mandatory quarantine for people coming on incoming flights from COVID-19 countries, and if you had recently traveled to China or parts of South Korea. They had strict hospital and quarantine regimens for potentially infected people, and they took their temperatures twice daily to follow them. There was extensive tracing of contacts. They did cancel mass gatherings, but they kept the schools open. And for students who went to school, they had their temperature taken when they entered class. And at the beginning of class, a photo was taken so that if someone was infected later and had symptoms of COVID-19, they could tell who was surrounding that infected student by the photo that was taken at the start of class. Singapore also developed quickly a serology test for blood antibodies for use starting late February. Taiwan. Taiwan is 100 miles from mainland China. They've had conflicts with China for years and decades. They're not very trusting of China. And basically the attitude of the Taiwanese people is that anything that comes out of China really can't be very good. They also had a memory of the severe acute respiratory syndrome in 2003 that was caused by another coronavirus. So that recent coronavirus infection still is in the memory of the Taiwanese people. Taiwan is a country of 24 million people. They had their first COVID-19 case on January 21st, but the day before that, they were already starting to activate their system by getting the Central Epidemic Command Center involved. At the end of January, they had the second highest number of cases in the world, but they sprang into action as soon as this mysterious illness in Wuhan was reported. They did widespread testing. They inspected travelers from Wuhan starting at December 31st. They had a self-quarantine tracking system. They ramped up production of medical equipment in January, and they did not have severe restrictions such as lockdowns and school and nursery closures. But because of their rapid action initially with testing, tracing, and quarantining, they were able to control the infection. Next country, South Korea. This is the model country that we're looking to at this time. It has a population of 51 million people. It has a memory of MERS, that Middle Eastern Respiratory Syndrome, also caused by a coronavirus, and they were infected in 2015 with MERS. They had one of the larger initial outbreaks of COVID-19 outside of China, but as recently as today, they only have 259 deaths and 10,962 cases. So they controlled that infection well, starting out as one of the larger initial outbreaks outside of China. They slowed the spread without lockdowns. They did free mass diagnostic testing, 20,000 tests a day at over 500 screening clinics, and they had hundreds of drive-through booths. The government had websites and mobile apps that showed people where people were tested and how many people were tested. And South Korea followed the WHO, World Health Organization, recommendation of isolation and widespread contact tracing to break chains of transmission. An author wrote in Foreign Policy that South Korea is showing how this model ultimately pays off in reducing spread, taking pressure off health services, and keeping its death rate one of the lowest in the world. This is a chart that shows the COVID-19 experience in the United States and South Korea. So on January 21st, both of our countries had their first confirmed case. At that time, the unemployment rate in the United States was 3.6%, and in South Korea, 4%. On March 3rd, we had 9 deaths compared to 28 deaths in South Korea, and the unemployment rate in the United States was 4.4% compared to 3.8% for South Korea. But by May 11th, the United States had 81,285 deaths, and our unemployment rate jumped to the greatest unemployment rate since the Great Depression of 14.7% unemployed. This compares on May 11th to South Korea having 256 deaths and maintaining an unemployment rate stable at 4%. And this was because of their action taken on testing, contact tracing, social distancing, and a healthcare system that was prepared to manage a pandemic. Denmark, a country that had another quick response, they enlisted their future doctors, nurses, and other medical trainees to help with this new pandemic. They did widespread testing, even drive-through testing for anyone with common cold symptoms. They experienced problems with their commercial testing kits as well. And because of that delay, the country just decided to be innovative. And so what they did is they circulated the chemical formula for testing across the country so that each lab could formulate a test. And they enacted emergency legislation that some consider the most extensive since World War II, giving national authorities sweeping powers for mandated testing, quarantining, and to vaccinate when a vaccine became available. So the head of the University of Copenhagen Medical School stated, "We have a direct line of communication from the national government to the regional government to hospital directors." So there's a clear example of how the leadership worked and the chain of command in managing a pandemic. Georgia, the country I mentioned previously, was the most recent enactment of a universal healthcare system in 2013. It's a small country of 3.7 million people with a struggling economy, but still, despite that struggling economy, they were able to pass universal single-payer healthcare for their people in 2013. At the end of February 2020, they had school closures and implemented widespread diagnostic testing. So there's a country of only 3.7 million people and a struggling economy that somehow managed to figure out how to do diagnostic testing. And so typical of Georgia and the modesty this small country has, a journalist from Georgia reported, "I think the fact that the government took it seriously from the very start has helped." Next is Iceland. Iceland has tested more people per capita than anywhere in the world. This happened early on. And at that point early on, they had tested more people than anywhere else in the world, and therefore they had the highest per capita infection rate at that time. Iceland is an example of a good public-private partnership because for testing, they had help from the private medical research company in Reykjavik. The name of that company is Decode Genetics, who cooperated with the National University Hospital of Iceland in developing COVID-19 testing. Iceland had a meticulous and quick response. They had aggressive testing and contact tracing. They declared a state of emergency on March 6th when the first 2 community cases were confirmed, and 3 days later, they implemented a 14-day quarantine for all Icelanders entering their country. They closed universities, but not schools and nurseries, which allowed parents to work. A journalist from Iceland reported, "Our growth has not actually become exponential due to these early measures of quarantining people who have likely been exposed to the virus." Germany has an amazing infrastructure for healthcare. It's just incredible the supplies that they have and how they're equipped to handle a pandemic. A very well-resourced universal healthcare system. They have 3 times the number of ICU beds than Spain, and Germany has more spare ICU beds than all of Italy's ICU beds. In Germany, it was projected that the country would need 12,000 beds in the hospital at the peak of the pandemic, and Germany has over 147,000 hospital beds. They have a large capacity to allow treatment of coronavirus patients from other countries, such as Italy, Spain, and France. They have private and public laboratories who have partnered to allow massive testing capacity of over 100,000 tests per day, and they have enough ventilators to meet unforeseen demand. The leaders in Germany have endeavored in recent years to improve the care in that country. Now, they have a high infection rate, but their death rate is rather low in Germany than other affected countries. And the feeling is that the reason for that is that the high infection rate, but rather low mortality rate, is because so many young people returned from ski trips in Italy and Austria with infections, but because they were young, they were able to survive the COVID-19 infection. Germany implemented more testing as the lockdown was scaled back. Now, I do need to mention that Germany is one of the countries that has seen a slight uptick in infections as they decrease their restrictions. We've seen this in Taiwan as well, and China. So there's a cautionary word about opening too quickly, and these countries are starting to see that you have to be careful when you open your economy again, because it can cause an uptick in infections. Finally, as far as foreign countries, we'll talk about Canada, our neighbor to the north. They have more expansive testing than we had. Their infrastructure for testing and contact tracing was established in January and February. Canada has a memory of a recent pandemic, also a recent epidemic rather, in 2003 when they were infected with SARS, the severe acute respiratory syndrome. And they were the only country in the world outside of Asia that had deaths from that virus. So that sticks in the memory of the Canadian people and made them more mindful to prepare for a future epidemic. They have a well-funded public health care system, and the criteria for who can be tested for COVID-19 was not as limited as in the United States. Justin Ling wrote in Foreign Policy magazine that Canada has spent the past 2 decades preparing for this moment. By catching cases early and investigating their origins, Canada has blunted the impact of the virus thus far. So now we'll talk about the United States. And I wish that I could say that our country had a better response to this pandemic, but in all honesty, our country's response has been poor. It's been disastrous. We lead the world in the number of infections and the number of deaths by far. A lot of what I'm going to talk about now is from a New York Times article of April 11th, 2020, entitled, "He Could Have Seen What Was Coming Behind Trump's Failure on the Virus." This is a picture of President Barack Obama delivering a speech to the National Institutes of Health in 2014. And at that time, it seems that President Obama was quite prescient in his view of a future pandemic. He stated that there may and likely will come a time in which we have an airborne disease that is deadly. He warned that we have to put in place an infrastructure to deal with such a pandemic. And he said so predictably that if and when a new strain of flu, like the Spanish flu, crops up 5 years from now, or a decade from now, we've made the investment and we're further along to be able to catch it. This was said in 2014. He talked about 5 years from then, and here we are with COVID-19 in 2020, starting at the end of 2019. So there was a directorate, a National Security Council Directorate for Global Health Security and Biodefense, created in 2016 under the Obama administration because of that administration's response or experience with the 2014 Ebola epidemic. And the purpose of that directorate was to prepare for the next disease outbreak and prevent it from becoming an epidemic or pandemic. Beth Cameron was the former senior director of that directorate, and she said, "In a health security crisis, speed is essential." In 2018, that team, that directorate, was dissolved. The leader was fired, and the other members of the team were dismissed from that team. And Beth Cameron wrote in the Washington Post that when President Trump took office in 2017, the White House's National Security Council Directorate for Global Health Security and Biodefense survived the transition intact. 1 year later, I was mystified when the White House dissolved the office, leaving the country less prepared for pandemics like COVID-19. The timeline for the United States on COVID-19 will be described in these next few slides. But let's go back to January of 2019 to August of 2019. Members of the Trump administration from Health and Human Services conducted a war game called Crimson Contagion. And they postulated that there would be a viral infection that started in China with people traveling on planes, having high fevers. The first US case would be in Chicago. And they predicted from that war game exercise conducted over all those months, that the United States would have 110 million infections, 7.7 million hospitalizations, 586,000 deaths, and they published the findings of their report in October of 2019 to the Trump administration. Just a couple months later, in December 2019, a cluster of pneumonia cases of unknown cause was discovered in China. It was felt that the origin of this COVID-19 infection was the Hunan seafood wholesale market. It's called a wet market, and the conditions in that wet market are very nasty and unsanitary. Live animals are stacked one on top of another in cages. On the ground, you can have blood, excrement, and the guts, frankly, from animals that are in that market. So it's a very unsanitary place. The infection of COVID-19 was felt to have started in a bat. There are many species of bats in China, and bats can harbor numerous viral infections. So it's called a zoonotic infection, where the bat was felt to be the original source of COVID-19, and then it jumped from the bat to one of the animals in the Hunan seafood market, and from that animal jumped to a human being, and then it was spread throughout the world. This cluster of cases was first reported to the World Health Organization on December 31st, 2019, but even a day before that, there is an email sent from a Health and Human Services attaché of the United States who was in Beijing. He reported back to the United States Health and Human Services office that there's some strange infection going on in China, and it seems like it's like SARS, and we need to be aware. So this communication happened at the end of December. The National Security Council received intelligence reports predicting spread to the USA within weeks, and it would be similar like how SARS spread in 2003 with asymptomatic spread. Matthew Pottinger, a deputy national security advisor, received a call from an epidemiology friend in Hong Kong who warned him that something like SARS is going on in China. And Matthew Pottinger passed this on to others within the administration, but some in the administration, such as Economic Advisor Lawrence Kudlow and Steve Mnuchin, Treasury Secretary, worried about talking much about this infection because of the economic fallout that would occur. But in the meantime, while they were debating about how to deal with this and how to communicate it, 14,000 travelers a day from China to the US were arriving during these days of debate. Now this is important, the first confirmed case in the United States was in mid-January, a traveler from Wuhan to Seattle, Washington. So we had COVID-19 entered our country in mid-January. On January 17th, the WHO provided testing instructions that were developed by a German researcher. They made these testing instructions available to any country on how to manufacture COVID-19 testing, but our CDC opted to develop its own test. On February 5th, the WHO shipped out 250,000 test kits to more than 70 labs worldwide. And at that time, the CDC found that their test kits were actually flawed and had to be remanufactured. This set us way behind and delayed widespread testing, which is so critical at the start of a pandemic. Now, not only did we have huge problems with testing at the beginning of our COVID-19 pandemic in the United States, but the leadership minimized the infection. We were told that it would be just like the flu, that it would go away, that when the warmer weather arrived in April, that the virus would be gone, that we had 15 cases on one day, but in a few days, we'd be down to 0 cases. But here's an example of the minimization of the seriousness of this infection when President Donald Trump sat down with CNBC's Joe Kernan at the World Economic Forum in Davos, Switzerland. Joe Kernan of CNBC asked the president, "Are there worries about a pandemic at this point?" And President Trump said, "No, not at all. And we have it totally under control. It's one person coming in from China, and we have it under control. It's going to be fine." Now, there's a group of people I need to tell you about. They're called the Red Dawn Group. They're named after a movie that was from the 1980s where the United States was invaded by a foreign power. And in response to that invasion, this Red Dawn Group got together to try to figure out how to deal with these foreign invaders. Well, there's a group now of infectious disease and public health experts from the government and universities that have formed a group to talk about infections like we're having now, and they've named themselves the Red Dawn Group. One of the members of this group is an infectious disease doctor at the University of Nebraska named Lawler, and I think because of his sense of humor, he'd be an interesting character to meet. But what he said in a communication from January 28th, likening COVID-19 to just the common flu, he likened it to other great understatements in history, such as Napoleon's retreat from Moscow, calling it just a little stroll gone bad, or calling Pompeii, which is buried in the dust of a volcanic eruption, a bit of a dust storm, or calling the bomb that was dropped on Hiroshima just a bad summer heat wave, and calling Wuhan just a bad flu season. There's Napoleon retreating from Moscow to the right, the Pompeii being buried in volcanic dust. Lower left, the mushroom cloud over Hiroshima, and there we have our Wuhan, just a bad flu season on the lower right. Continuing with the timeline, on January 20th, the first COVID-19 case was diagnosed in South Korea, and a national security biodefense expert in the United States urged officials to consider a quarantine for a city the size of Chicago. On January 30th of 2020, we had our first confirmed case of person-to-person transmission in the United States. And on that day, the WHO declared a global public health emergency. On February 2nd, Trump implemented the China flight ban, with foreign nationals with recent visit to China being barred from entry into the United States, and some Americans were quarantined. Now, this was a good move to ban flights of people from with a recent China visit, but the problem was it was enacted about a month too late. On February 21st, the coronavirus task force met, and they revisited that crimson contagion that I talked to you about before, when it was just a war game back in 2019. This time, they did a real-time version of the crimson contagion, and their conclusion was we need to move to aggressive social distancing. At the end of February, public health experts and others, such as Dr. Fauci, who we know well, Dr. Redfield, the CDC director, and Alexander Azar, Health and Human Services director, presented a document called the 4 Steps to Mitigation to President Trump. But at that time, President Trump was not interested. Instead, he wanted to focus on his messaging and confident predictions of success with this infection. And the New York Times reports that squandered vital time as the coronavirus spread silently across the country occurred. Now, at the end of February, when this 4 Steps to Mitigation document was presented, we had, on February 26th, 15 cases of COVID-19. On March 16th, when social distancing measures finally were approved, the number of infections had climbed to 4,226. March 1st, Health and Human Services announced an investigation into why did we have defective kits from the CDC for coronavirus testing. On March 11th, the European travel ban was announced in the Oval Office. On March 13th, President Trump said he was not responsible for COVID-19 testing failures. On March 16th, the social distancing was finally announced. and was to last only 2 weeks. On March 17th, we had coronavirus in all 50 states. And on March 18th, the coronavirus relief package was signed by President Trump, allowing for free testing for COVID-19, just only testing, but not treatment. Now, keep in mind that we had the person coming in from China to Seattle in mid-January. And here we are 2 months later, requiring an act of Congress to allow all people in the United States to be tested for COVID-19. And testing, as I've mentioned so many times, is such a critical first step in managing a pandemic. But it took an act of Congress 2 months too late to be able to do it. So from ABC News, reported March 13th, Trump says he's not responsible for testing problems. And it goes on to say, South Korea's government-run health system moved fast with China, the initial epicenter of the outbreak, being so geographically close. South Korea quickly ramped up to more than 10,000 tests per day, even setting up drive-through clinics in which patients could get tested for free without getting out of their cars. And they also state in this article that as of Friday, the CDC estimated that 13,600 tests had been run, compared to 250,000 done in South Korea. So Li Fang wrote in The Intercept on April 1st that while much of the world moved swiftly to lock down crucial medical supplies used to treat the coronavirus, the US dithered, maintaining business as normal and allowing large shipments of American-made respirators and ventilators to be sold to foreign buyers. So this equipment that we so desperately needed in this country was still being sold to foreign countries in March of this year. On March 26th, the United States had more coronavirus infections than any other country in the world. And on April 11th, we became the world leader, unfortunately, in COVID-19 deaths. And at that point, we had more deaths than occurred in Pearl Harbor or on 9/11. So here we are, the country with the most infections and the most deaths. So what's to be done about that? Well, one of the first actions was on April 14th, where President Trump stopped payments to the World Health Organization. That does not seem to be a helpful step, to stop payments to the organization that's helping to manage a worldwide pandemic. He followed that up on April 21st by demoting Dr. Rick Bright, who was a physician who had spent his entire career working on vaccine development. He was the director of the Biomedical Advanced Research and Development Authority since 2016. He was a very experienced physician and scientist, but he was dismissed and demoted from that position because he had a dispute with President Trump over the use of hydroxychloroquine to treat COVID-19. And it's since been shown that hydroxychloroquine does not help. And in fact, patients treated with hydroxychloroquine can have up to 2 times the number of heart problems, such as heart attacks and arrhythmias, from receiving hydroxychloroquine when they have COVID-19. And Dr. Bright said this decision to demote him was based on politics and cronyism and not based on science. Here's a quote from Dr. Bright to the New York Times: "Sidelining me in the middle of the pandemic and placing politics and cronyism ahead of science puts lives at risk and stunts national efforts to safely and effectively address this urgent public health crisis." On April 28th, US coronavirus deaths at that time, over 58,000, exceeded those from the Vietnam War. On April 29th, another misstep where the National Institutes of Health withdrew funding for EcoHealth Alliance, which is a US nonprofit that researches emerging diseases, including coronavirus. As I mentioned previously, it's so important to anticipate and prepare for the future, but if you're stopping research that is involved with emerging diseases, it's a big mistake. On May 13th, today, the US coronavirus deaths are tabulated at 84,187. This accounts for 28% of the world total. And we also have the most cases in the world at 1,418,504. That accounts for 32% of the world total. Now, the United States population makes up only 4.3% of the entire world. And we see countries such as China and India with much lower death rates. And these countries have populations 4 times that of the United States. China has had 4,633 deaths as of today. India, 2,551 as of today. So one of the concluding statements in that New York Times article I mentioned at the start of the US timeline, statements being made was that the chaotic culture of the Trump White House contributed to the crisis. A lack of planning and a failure to execute, combined with the president's focus on the news cycle and his preference for following his gut rather than the data, cost time and perhaps lives. So what are we talking about today? We're talking about how do we open up our country again, open up our economy after going through the social distancing process. Well, there was a document prepared called the Opening Up America Again document. And they talked about phase 1 being a gating criteria on how we would progressively open up the country. And one of the criteria in that Opening Up America Again document was that there should be a downward trajectory of documented cases within a 14-day period. But on April 29th, the Trump administration rejected a report from the CDC titled Guidance for Implementing the Opening Up America Again framework. And that report was researched and written by scientists to help faith leaders, business owners, educators, and state and local officials as they began to reopen the country. But the Trump administration stated that that report would not see the light of day. Now remember, in April, mid-April, the Trump administration was stating that we need to see a downward trajectory of documented cases within a 14-day period. I'd like to show you what happened prior to the opening up of the country on May 7th in the next slide. This is total confirmed COVID-19 cases from April 20th to May 7th when it was recommended that the country be opened up again. We do not see a downward trajectory. Instead, we see an upward movement, an upward line of number of COVID-19 cases. This is concerning. There's a lot of concern about opening up the country too fast and just worsening where we are now and setting us back even further. So let's talk a little bit about how does this pandemic affect patients. 45% of Americans have nothing in a savings account. This was determined by a Go Banking Rates survey in 2019. Another 24% of Americans have less than $1,000 in a savings account. And that survey showed that 51% of Americans avoided medical care due to inability to pay. So we have a healthcare system in our country that's not universal. That means not everybody has assurance that the care they're seeking is going to be paid for. And if you're one of those people without access to healthcare that is affordable, and you have nothing in your savings account, you develop a fever and a cough, you likely have COVID-19, where are you going to come up with the money to go get tested? The COVID-19 test can cost hundreds, perhaps even a few $1,000s to be tested. And people without anything in savings simply don't have the wherewithal to get tested. So here we have an infected person that can spread this infection to dozens of other people, and we don't know about it because we don't have a process in place of universal health care where people can go get treatment and be tested, so it's known who are the people who have COVID-19 infections. Also, the impact on the American people is the linkage of health insurance to jobs. The Washington Post ran an article by Amy Goldstein that stated, first, the coronavirus pandemic took their jobs, then it wiped out their health insurance. She went on to say, in a nation where most healthcare coverage is hinged to employment, the economy's vanishing jobs are wiping out insurance in the midst of a pandemic. On May 7th, we learned that over 33 million Americans had filed for unemployment since mid-March. And on May 8th, the unemployment rate was reported at 14.7%, the worst since the Great Depression. So the Robert Wood Johnson Foundation and the Urban Institute stated, because health insurance is tied to employment for about half of the country, as many as 43 million people are expected to lose their health insurance due to the pandemic. Let's talk a little bit about the impact of this pandemic on healthcare workers. This is a picture of Derek Smith, who is a nurse anesthetist in New York City and was involved with that huge outbreak of infections, patients where New York City was the epicenter of our pandemic. And what he stated was, the last words I'll never forget, the response my patient gasped out between labored breaths to me and my team after we explained he needed to be intubated and placed on the ventilator. Those last words were, who is going to pay for it? And he stated, this situation is by far the worst thing I've witnessed in my collective 12 years of critical care and anesthesia. He went on to say, this country is truly a failed state, and it's so sickening to witness firsthand, more blatantly than ever. How has the pandemic affected physicians, emergency room doctors in this country? We're told that we should just let the market work and everything will settle out and be just fine. But here's an example of the market working against physicians, where medical staffing companies, Team Health and Envision, cut doctors' pay while spending millions on political ads. So what happened was, while cutting benefits for emergency room doctors and other medical workers, Team Health and Envision, two companies who are owned by private equity firms, spent millions of dollars on ads that were meant to pressure politicians working on legislations to cap out-of-network costs for Americans. This is the surprise billing we're talking about, where you think your healthcare is being paid for, but because you unfortunately are out of network, you're left with the bill because your insurance company is not part of that network. This is a publication in ProPublica, and it's really, this whole campaign by these two companies is such a cynical and deceptive way of using doctors to get what they want. Here's an example of what a physician thought about it. This was an Envision doctor who stated, they've always just been more worried about the bottom line than being appreciative of their people. Physicians don't feel like they're being heard and respected for what they do, but we still show up and take care of patients. This is part of what's breaking the system down. And here's an example of the ad from that campaign called Doctor-Patient Unity. So they're co-opting doctors here, saying that we're on the side of doctors when they're actually cutting the emergency room doctors' pay and benefits and directing money to Congress, saying, let's keep this surprise billing mechanism in place. And they're saying, Congress, let's provide doctors the resources to continue saving lives. It's just so false, deceiving, and cynical. It's just a disgusting way to treat those on the front lines of caring for COVID-19 patients. Neil Irwin stated in the Upshot in the New York Times that crises have a way of bringing to the fore issues that are easy to ignore in good times. So what do we need to do in this country to be better prepared for a pandemic? Well, we need to improve funding for public health infrastructure. Funding has been cut for public health since 2002. Only 2.4% of US government healthcare spending is directed to public health, where Canada spends 6% of their healthcare spending on public health. We have lost 50,000 frontline state and local healthcare employees since 2008, those that are involved in public health, such as contact tracing, and that's a 20% reduction. We have 700 CDC positions unfilled because of a hiring freeze that started at the beginning of the Trump administration. We need a cohesive, coordinated national system, a chain of command with clear leadership that can direct such a reaction to a pandemic. A reaction that predicts rather than reacts too late to a public health crisis. We need testing kits. We still do not have enough testing kits. We're supposed to be testing 900,000 patients a day, according to the Harvard Global Health Institute, and we're testing, even at this time, only about 300,000 patients a day. We need to have adequate personal protective equipment. There's an example in Illinois where the governor of Illinois had to secretly charter 2 flights from China to get the personal protective equipment he needed for his state. And he had to do it in secret because he was afraid that the federal government would seize those shipments and take them from Illinois. There's been a battle between the states competing with one another to get the equipment they need, and a battle of governors against FEMA. It's just been uncoordinated and poorly managed. We need to have adequate number of ventilators, and we need an adequate number of staff to manage a pandemic. And we've heard about the national stockpile not being available for the governors, that it was declared to be the federal government stockpile and not to be shared with the governors of the states. We also need a strategic allocation of resources. We need to direct resources where they're needed, not where the most profit can be extracted under the current market system. Rural hospitals are shutting down. This doesn't mean that rural patients still don't need those hospitals. And these shutdowns have happened more in the states that declined Medicaid expansion under the Affordable Care Act. We also have an example of a Philadelphia Center City Hospital, Hahnemann, closing down in September of 2019. And this is a hospital that was a 496-bed tertiary care hospital. It was a teaching hospital of Drexel University, established in 1848. And that closure not only depriving inner city patients of access to a quality hospital, but also the people who are in training. This closure displaced 574 physicians who are training as residents and fellows. And it was the largest displacement of physician trainees in US history. We have a specialty excess in this country. We have actually too many orthopods, too many cardiologists, and actually a shortage of primary care providers and mental health providers. We need to have a global budget for hospitals like police and fire. And we need to eliminate administrative waste of the current hospital billing system. An example of this is Duke University has 3 hospitals where they have 957 beds, but for those 957 beds, they have 1,600 billing clerks, almost 2 billing clerks for every bed in the hospital. An example of the bureaucracy and administrative waste of our current hospital billing system. We need to design redundancy so we have medical facilities that have space that can be quickly converted to hospital space from outpatient space and set up to provide beds for a pandemic surge. And finally, we need to look at the health, safety, and security of US people. The military has ready supplies for wartime emergencies, such as planes, boats, weapons, etc., but they're not used all the time. And the healthcare system should be similarly prepared, where we have a surplus of items that can be pulled into use when we need to deal with a pandemic surge. There's a quote by Sonia Renee Taylor that states, "We will not go back to normal. Normal never was. Our pre-corona existence was not normal other than we normalized greed, inequity, exhaustion, depletion, extraction, disconnection, confusion, rage, hoarding, hate, and lack. We should not long to return, my friends. We are being given the opportunity to stitch a new garment, one that fits all of humanity and nature. This is our opportunity in this time of upheaval to change things for the better." Medicare for All provides the benefits you see on this page. Comprehensive coverage. It covers preventative services such as mammograms and colonoscopy, care in the hospital, physician services in and out of the hospital, dental care, mental health services, medication expenses, reproductive health services, PT and OT, home care, nursing home care, and long-term care. It covers all medically necessary services without deductibles or copays. What we have on the left-hand column is concerns from our current system. And in the middle column, what Medicare for All can provide. One of the key issues now is that health costs deter people from seeking testing and treatment. But Medicare for All would cover everybody for all medically necessary care without premiums, copays, or deductibles. Patients would get the care they need without worrying about costs. Another issue is that mass layoffs force millions of Americans off their workplace health insurance. But Medicare for All would provide seamless, lifelong coverage that's not tied to employment. Americans would enjoy the freedom and security of comprehensive coverage no matter what happens in the economy. Right now, we have under-resourced hospitals that face a surge of patients from a pandemic and having costly critical health needs. But Medicare for All could redirect $600 billion every year in administrative waste annually to patient care and public health. Hospitals would be funded through an annual global operating budget, which would be increased during emergencies. Public health authorities could move supplies quickly to meet local needs. And another key concern is that public health authorities don't have accurate data to make timely informed decisions, because our current electronic medical record system is such that various healthcare systems don't talk to one another. But under Medicare for All, a unified national electronic medical record system would give officials real-time data from every hospital and clinic in the nation and empower leaders to make quick policy decisions and direct personnel and equipment where needed. I experienced a unified national electronic record system while working at the VA. That system was called CPRS, so that I could see the record of any VA patient who came to see me who had received health care elsewhere in our country. And I knew that my patients, if they went to Florida or Arizona for the winter, would have their records from Minneapolis available to the Florida doctor or Arizona doctor, because throughout our country, the VA CPRS record system allows physicians in the VA system anywhere in the country to access a patient's records. And this is such an advantage as a provider. If you're seeing a patient and you know nothing about them, it's a big disadvantage to both you as the provider and the patient, because the patient is just a complete mystery to the patient without any knowledge of what their record shows. And I should also mention that the VA, unlike the Medicare system, the VA allows for drug price negotiation, where the VA obtains an average of a 40% discount on drugs by negotiating drug prices. And in this country currently, the laws for Medicare state that it is not permitted, it is illegal to negotiate drug prices with drug companies. And that's a situation that needs to be fixed so that we can save money for our country, save money for our patients by doing drug price negotiation like the VA, and try to get somewhere in the neighborhood of a 40% drug price reduction on medications for all patients in the United States. So what can you do? What can you do to improve our healthcare financing structure and allow all residents of this country to have universal health care? Well, you can join Physicians for a National Health Program Minnesota, and there is our website address. Also consider joining Healthcare for All Minnesota. Both of our organizations have speakers available for your group. You can learn more about our healthcare system by watching an excellent video that's about 55 minutes long. It's free. You can stream it at fixithealthcare.com. It's a business perspective on what's wrong with our current healthcare system and how Medicare for All can vastly improve it. Go to the pnhp.org website, where there's a wealth of information. There's an excellent book written by T.R. Reid, a journalist who went to various countries with a shoulder problem and experienced their healthcare system and compared it to the United States in his book called The Healing of America. And another recommended book is one by Senator John Marty of Minnesota called Healing Healthcare, The Case for Common Sense Universal Health System. We need to discuss the urgent need to restructure healthcare with our family, neighbors, and friends. We need major societal changes on a scale like those enacted during the Great Depression when we received the New Deal. Consider hosting a house party with friends and neighbors and family. Show them the Fix-It video and discuss it afterwards. Okay, everybody, I am at the most important point of this slide, and I'd like to have you all listen very carefully. We can have all the meetings we want, we can do all the complaining we want about how poorly our country prepared for and managed this pandemic and how broken our healthcare system is, but we need to work for what we deserve. It's like anything in life, you have to work for what you deserve, and the same applies to the legislation that's necessary to pass bills that give us Medicare for all. Now, for those who haven't done this before, I want to tell you this is so easy. It's not going to take a lot of your time, probably less than 3 minutes for each phone call you make. And don't be afraid to do it. You are not going to be talking directly to your senator or your representative. You're simply going to be talking to one of their staffers, and all you have to ask that staffer is, please pass this message on to Senator so-and-so or Representative so-and-so. It is so easy, and there's no need to be afraid. So here's what you do. You just call 202-224-3121. You'll be connected with the Capitol operator. You just tell the operator, I'd like to be connected to, say, Senator Tina Smith's office. Then what you do is you ask Senator Smith to support the bill that involves the Senate, which is the Healthcare Emergency Guarantee Act. That's the Sanders-Jayapal bill. Bernie Sanders, of course, is a U.S. Senator, and Representative Jayapal is in the House of Representatives. But that particular bill involves both chambers, so you need to call both your representative and your senator to ask them to support the Healthcare Emergency Guarantee Act. Also, ask your representative to support the Medicare Crisis Program, because that is a second bill that's in the House only. It's not in the Senate yet, but it's in the House, and so you need to ask your representative to support both of those bills, please. As far as your senator, though, it's only the Healthcare Emergency Guarantee Act, because that's a bill involving Bernie Sanders in the Senate and Representative Jayapal in the House of Representatives. So it's just 3 phone calls. 1 phone call to your U.S. representative asking the representative to support both bills, and 2 calls, 1 to each of your U.S. senators asking them to support the Healthcare Emergency Guarantee Act. While you're at it, when you're talking to your representative, ask them to co-sponsor H.R. 1384, which is the Medicare for All Act of 2019, if they're not already a co-sponsor. If you know that they're already a co-sponsor of that H.R. 1384, thank them very much for being a co-sponsor. Again, this is the most important thing that you can do in getting this done. It's going to require legislation, and we need to take action. And this is so easy, takes so little time, that just reserve some time in your day, just 10 minutes to make these calls, and you'll be done. You'll have done your civic duty. Thanks for paying attention to that in particular. You can write a letter to the editor or an op-ed. Use social media toolkits such as PNHP available to tell your story, to post to your elected officials, to post educational materials, and engage your family and friends in conversation. And finally, don't forget to vote and know who's really on your side to give you the health care you deserve. We need to obtain universal single-payer health care. We deserve it for our country. And like anything else in life, we have to work for it. So unless you're born into a family of great wealth, you know what it is to work for things and get what you need to deserve, and get what you deserve. So please vote, please take action, and let's get what we need for healthcare for our country, and campaign for single-payer candidates. Finally, let's just take a look at what has this pandemic shown us. It's shown us that we are all human beings, that we are vulnerable to illness and death, that we are an interconnected web of humanity. We are all worthy. We need to hold healthcare as a human right, and to say that some people are deserving of healthcare and others are not deserving is a statement of selfishness, and it's a statement of greed. We need to do better than that, and we can truly all do better when we all do better. Thank you for your attention, and I'll turn it back to Jen.
Thank you so much, Dr. Engelhart. We truly appreciate your time tonight and everything that you shared with us. We hope that you will join us on pnhp.org and HCA-MN.org to find out more about what you can do to make universal single-payer healthcare a reality. Thank you, everyone, for joining us, and be well.